Yeah, like please.
Thanks, Sunilji. Very good evening, everyone. And in view of the Glaucoma Awareness Month, we'll be having two glaucoma cases in today's PG program, where two of our hopefully brilliant residents will be presenting some lovely cases. Thanks to Dr. Shumaila Khan, who's a junior resident in NKP SIMS Nagpur. Sorry for that, that's a mouthful. And ably mentored by Professor Rekha Khandelwal Madam, who's the professor and head of her department, and Dr. Deepa Kumar, who's an associate professor in the same department. We also have Dr. Anushri Kadam, who's another JR3 in the Department of Ophthalmology in the D.Y. Patil Medical College in Navi Mumbai, and ably mentored by Professor Sumita Karandikar, professor and head of the department. So wish you both all the very best. We have two excellent examiners who are going to be asking you all questions, and both very kind and considerate. Dr. Sachin Dharwadkar from Mumbai and Dr. Devang Angmo from RP Center AIMS in New Delhi. A big thank you to both of you all to spare some valuable time and be a part of our PG case presentation program. And the entire program will be moderated, curated by member of the scientific committee, Professor Archana Vare. I am, of course, Dr. Piyush Bansal, chairman of the scientific committee, and a warm welcome to everybody. All the best to both of you all, and over to you, Professor Vare.
Okay, at the outset, I would like to congratulate Dr. Piyush Bansal for his grand victory, and now he is the member of scientific committee at All India Ophthalmological Society. So huge congratulations, Dr. Piyush. And yeah, with that, we'll start our first case presentation. So both the case presenters, Dr. Sumaila and Dr. Anushri, will be getting around 10 minutes for your presentation. So first, we'll go ahead with Dr. Sumaila Khan. And,
Yes, thank you, ma'am.
Yeah, and I'm thankful to her mentors, Rekha ma'am, um, and Dr. Deepa. Rekha ma'am, she's the examiner tomorrow, but still she's traveling, but still she has spared her valuable time in joining us today. So we are really thankful to you, ma'am. And now we'll move ahead to Dr. Shumaila Khan, and she'll present her case. Yeah.
Hello, good evening, everyone. Myself, Dr. Shumaila Khan, a third-year resident in NKP SIMS, Nagpur, and my mentors are respected Dr. Rekha Khandelwal ma'am, professor and head, and Dr. Deepa ma'am, associate professor, NKP SIMS, Nagpur. So, we had a 45-year-old female who came to our IOPD with complaints of diminution of vision in her left eye since 2 months. Since 12 months. She also had intermittent pain, redness, watering, and colored halos since the last 2 months, for which she had visited a private practitioner. But there was no history of any trauma or flashes of light, and there is also not any significant use of ocular medication. But she was put on anti glaucoma medication 2 weeks ago by a private practitioner. So looking at her current refraction, she has been using glasses since last 1 year with minus 0.25 spherical and minus 0.50 130 degree in right eye and plus 1.25 in left eye with a correction of plus 1.50 with no improvement in the left eye. So coming to the ocular examination, the right eye was well within normal limits, with her visual acuity being 6 by 6, anterior chamber normal depth with Von Herrick grade 3. As we can see, the pupil is central circular 3 millimeter in size and it was reacting briskly to light. No iris abnormality was noted, as well as her right eye fundus was average within normal limit with average size disc, cup to disc ratio 0.4, and peripheral retina and macula were also normal. And the intraocular pressure at the presentation was 12 millimeters of mercury at 11 a.m. by applanation tonometer, and gonioscopy revealed all angles were open. Coming to the left eye ocular examination, her best corrected visual acuity was 6 by 36, with circumciliary congestion as can be seen in this image. Epithelial and stromal edema was also seen. Endothelium, we can see hammered silver appearance on retroillumination. Anterior chamber depth was narrow, was shallow with Von Herrick grade 2. Pupil is 2 to 3 mm oval in shape. You can see a correctopia at 4 o'clock position. Multiple peripheral anterior synecdoche were noted from 4 to 6 o'clock, 7 to 10 o'clock, and at 12 o'clock. We could also see various atrophic patches over the iris. And of course, the media was hazy because of corneal edema, average size disc with cup to disc ratio of 0.9, and peripheral retina and macula were normal. Her IOP at presentation was 22 millimeters of mercury, whereas it was 32 2 weeks ago, after which the private practitioner started her on anti-glaucoma medication. On gonioscopy, all the angle structures were not seen. Broad, high, peripheral anterior synecdoche were seen, which were going above Schwalbe's line in all the four quadrants. So this is again the depiction of anterior chamber and gonioscopy of the right eye, which was normal, whereas left eye shallow and pars was seen. So this prompted us to do visual field 24-2 white on white standard automated perimetry. The right eye glaucoma hemifield test was within normal limit, whereas left eye showed average thickness of 44 and thinning of RNFL in all the quadrants. The mean deviation being minus 19.15 decibels, which showed it to be severe category according to Horab-Anderson criteria. We also did RNFL OCT with the right eye showing double hem pattern, whereas left eye advanced RNFL loss was seen. So this prompted us to do specular microscopy, which is a definitive academic evidence. The normal right eye showing normal hexagonal shape of endothelium cells with normal count of 2,475, whereas left eye shows abnormal endothelium with large spaces between cells and low cell count of 1,429. Eye cells could be seen. These are large pleomorphic dark cells with a bright central spot. Color of the cells was reversed with black surrounded by white border. So this dark bright reversal pattern is pathognomic of eye cells. So thus we made a diagnosis of iridocorneal endothelial syndrome with Chandler being its clinical variant in the left eye. Differential diagnoses are the other clinical variants of eye syndrome, that is progressive iris atrophy, which should have marked iris hole formation, that is stretch holes and melt holes. Cogan-Reese syndrome, which should have pedunculated iris nodules or nevi, but our variety, that is Chandler syndrome, had marked corneal edema, and it also matches our patient's hammered silver appearance of the endothelium. Other differentials being axonal Rieger syndrome, which should be bilateral, posterior polymorphous corneal dystrophy, which is also bilateral, and primary angle closure glaucoma, which is also having bilaterally shallow AC. So this is a very crisp table which I have made of all the three clinical variants of eye syndrome. The first one being Chandler syndrome, which shows not full thickness holes, whereas progressive iris atrophy shows full thickness holes. Chandler syndrome has correctopia. Progressive iris atrophy has polychoria. Chandler syndrome shows marked corneal edema, which is absent in the other two clinical variants, and peripheral anterior synecdoche are present in all the three clinical variants. So coming to the management, medical management is usually temporary due to past formation. So we went on to surgical line of therapy and patient was posted for trabeculectomy with MMC left eye. High rate failure, that is iris membrane formation, must be explained to the patient. This is the formation of an abnormal membrane over the endothelium which crosses the angle structure and over to the anterior surface of the iris. It contracts and results in correctopia and angle closure glaucoma, and also overgrowing the internal ostium, resulting in failure of the surgery. So the patient was planned for trabeculectomy with MMC 2-minute. Preoperative IV mannitol was given. Phonics-based conjunctival flap for better exposure. Wide diffuse posterior application of MMC to avoid ring of steel and achieve low-lying bleb. Superior triangular flap was taken. Trabeculectomy with MMC 2-minute was done after paracentesis. Deep block excision was done to create internal ostium with Kelly sponge. Peripheral iridectomy was done for better control of aqueous outflow. Scleral flap sutured and conjunctival flap sutured within a watertight manner. Watertight is necessary here because we need to avoid bleb leak, as well as it prevents infections like endophthalmitis. Bleb and AC were well formed after the surgery. This is the post-op day 1 picture, which shows visual acuity to be 6 by 36, diffuse bleb, CDL negative, mild corneal edema, AC well formed with cell 2+, no hyphema or RBCs. Correctopia was present with nucleus sclerosis grade 1 lens. Fundus disc was seen, posterior pole appeared normal, and IOP was 14 millimeters of mercury. We started the patient on steroids, antibiotics, and cycloplegics for the next 2 to 3 months. This is the post-op 6-week presentation, visual acuity being 6 by 24. Good diffuse bleb, cornea was clear now, iridectomy patent, fundus, media slightly hazy, of course, due to lens changes and not due to corneal edema. CDR was 0.9, IOP 12 millimeters of mercury. First, from the case, from resident point of view, we can say that medical management aqueous suppressants can be used, but avoid myotics like pilocarpine as they may worsen iris pulling and synecdoche formation. For corneal edema, we should use hypertonic saline drops or ointment, and the failed trap warning, as I explained already, should always be given. Always inform the patient that failure rate for infiltration surgery is higher in eye syndrome than in primary open angle glaucoma due to the creeping nature of the abnormal endothelium membrane. So, a 45-year-old female
Shamila, you
present.
have to sum up your case.
Yeah, ma'am. This is the last slide. So
Okay.
this is a very common finding of a lady coming to our OPD with diminution of vision and colored halos, which mostly point towards PACG in Asian countries. And of course, the practitioner started her on pilocarpine and timolol, but this comes out to be a case of secondary narrow angle glaucoma due to eye syndrome. So it's always better to examine both the eyes to rule out primary glaucoma, do gonioscopy in all the cases. Ancillary tests are needed to confirm the diagnosis in certain cases of secondary glaucoma. These were my references. Thank you so much from Team LMH.
Yeah. Congratulations, Dr. Shumela, for presenting a very nice case, and congratulations to your mentors also, Dr.
Thank
Deepa
you.
ma'am and yeah, Dr. Rekha ma'am. And now I would like to request Dr. Devang ma'am to ask questions to Dr. Shumela.
So, Dr. Shumala, what was the age of this patient?
She was a 45-year-old female.
Okay, so what was your differential diagnosis? So,
My differentials were primary angle closure glaucoma, and I also had in mind other like posterior polymorphous corneal dystrophy, or it could have been Fuchs endothelial dystrophy. And also, sometimes it also came to my mind that without pupillary block, it could have been the secondary causes like eye syndrome, or yes.
so looking at your case, the way it has present, first of all, PACG is bilateral, okay?
Yes, ma'am.
The unilateral case. So definitely it doesn't. So first and foremost thing is that definitely this won't be your first differential.
Ma'am, the unilateral causes of shallow AC being uveitis.
Yeah.
Uveitis also came
And
to
now,
my mind.
now you are coming on to the track. Okay, so you are
Yes, ma'am.
supposed to when you are asked an exam, you're supposed to uh,
Yes,
uh, answer as per your case.
yes,
Okay,
ma'am.
one is uveitic, yeah.
Uveitis, or it could have been lens subluxation, plateau iris configuration, or it could be ciliary body edema, choroidal effusion, or
Those unlikely, but most commonly that we see is uveitic. They also do present
uveitis.
like this. Yeah,
Yes,
definitely. And Fuchs and posterior polymorphous, usually they are, presenting late. They're not presenting such early. Like,
yes, ma'am.
what is the characteristic of eye syndrome?
Ma'am, eye syndrome has three clinical variants. It has Chandler syndrome, progressive iris
What is the
atrophy.
characteristic that when a patient, comes to the OPD and you know that these three things
Yeah.
are there, then this is known as eye syndrome.
Ma'am, unilateral corneal edema, correctopia, iris holes and stretch holes, atrophy. These things on the ocular examination points towards the eye syndrome, which prompts us to do the specular microscopy and further investigations.
So what is more important is not only this, eye syndrome has a characteristic age group, which
Yes.
is
Ma'am, it's 40 females in the age group of 40 to 50 years of age, 30 to 50.
it is not, yeah, it is middle age.
40 to 60 years of age.
30 to 50, 60 is old age. Okay. So it's young middle-aged females who will come, and your case is bang that.
Yes.
The middle-aged female. So that
Yeah.
is the clinching thing that especially for secondary glaucomas, that is the thing. And what investigations would you like to do in such patients?
We proceeded from fundus examination to IOP, then we proceeded on to gonioscopy, then we went on to do a specular microscopy, as well as anterior segment OCT should also have been done, but this was not done in our institute. But the
My
specular
question is,
microscopy
anterior
was,
segment OCT is it mandatory?
ma'am, we can see fine pre-iridial membrane in
Which you can
AS
see on
OCT
gonioscopy also.
to know the extent of pus.
That you can do on gonioscopy also.
Sometimes, because of the corneal edema, the structures are not entirely visible on gonioscopy, so we can do ASOCT for that. but it's not mandatory.
That's what. So it is not mandatory.
Okay.
Asusity
Yeah.
doesn't come in the diagnosis. Okay.
Yeah.
So it's mainly gonioscopy and clinical
And
findings.
yeah.
So what do you see on clinical findings?
Ma'am, in my case, I could see corneal edema, I saw keratoopia, and I saw atrophic patches on the iris.
Okay, so
Yeah.
which means that which type? So eyes has how many
Yeah.
variants?
Ma'am, it
I think she has lost the connectivity. She's not there. Maybe Deepa ma'am or Rekha ma'am, can you call her and tell her that she has to join again?
Hello, Archana. I
Yes,
told her. I told her to join. I
yes,
think she lost the
correct.
connection.
Yes, ma'am.
Yeah, yeah. I told her to join. I don't know where is she now.
We'll wait for like 2
A
minutes.
minute or so.
Yeah.
Yeah.
Otherwise, we'll ask Anushi to
Yeah.
present, and then
Yes, sure,
Sachin
sure.
sir and Devang ma'am can ask them later.
Yes,
Is
yes.
it okay, ma'am? Devang ma'am, is that okay?
Yes.
Yeah, actually, I had basically told Dr. Piyush that I had some important commitment. By 8:50, I have to leave.
Okay, no problem, ma'am. So can we proceed with Dr. Anushi's case, and then later we can discuss
Yeah.
together?
Yes.
Yes,
Yes.
can be done.
Sachin sir, is that okay with you?
Yeah,
Yeah,
fine. No problem. I'm here.
she's here.
I'm so sorry, ma'am. For that.
No, that's okay. So Devang ma'am and Sachin sir, both of you like can ask her questions. So
Yeah,
no,
Hala, you were saying something na, in the middle of thing. It was
Yeah, ma'am. My case comes under Chandler clinical variant of eye syndrome because there's prominently seen corneal edema. Yeah. And keratoopia was also there, but corneal edema is a characteristic of the first variant, that is the Chandler syndrome, rather than the other two variants.
So how do you, there are multiple reasons for corneal edema. So what investigations do you do or how do you confirm your diagnosis?
Ma'am, uh, it's not just the corneal edema, but there are some other appearances also which can be seen on the Chandler syndrome, that is a correctopia. And we confirm this by doing specular microscopy, where in my case, we could see eye cells, that is, the distorted pattern of the normal hexagonal endothelial cells was seen. So eye cells were seen with reverse dark bright reversal pattern, which is pathognomic of eye cells.
Usually eye cells are difficult to see on specular. What is more clinching?
Ma'am, a darker background with a bright spot in middle is the more clenching of it.
Yeah, but it's difficult to visualize that on specular microscopy. What is more
Silver hammered appearance or beaten bronze appearance of the endothelium
on on which
on s- on retroillumination slit lamp microscopy.
is it exactly retroillumination?
Um, no, ma'am. Ma'am, not exactly.
What are the other ways? What are the other ways of seeing the endothelium? That should give you a clue.
So by diffuse elimination, retroillumination, we can see the endothelium. Specular microscopy.
That is the answer that is expected.
Okay. Yeah.
Specular reflection, not specular microscopy.
Specular reflection. Yes, sir.
So once you diagnose such a patient, what do you explain to the patient?
Ma'am, we explained to the patient that though we cannot completely control this situation by medical management. Therefore, we proceed to the surgical line of therapy, as well as we also explain that there is high rate of failure because of the internal ostium being covered by the membrane. So we explain that the patient will not have a very good prognosis, but she needs to be under a complete regular follow-up.
So if the patient, you've done a trabeculectomy and the patient,
And later on, we can also prescribe or advise the patient for a DSEC, that is descemet endothelial is the keratometry, and PK, DMEC also in the further levels.
so if the patient comes to you with you've done a surgery and the patient still comes to you with high pressure.
Yes, ma'am.
Now,
We can start the patient on carbonic anhydrase inhibitors, and
why but some particular drugs are contraindicated when the endothelium are bad, right?
yes, ma'am. We should not. The prostaglandin analog is contraindicated here.
Why?
Ma'am, it leads to macular edema in this
Not in these
case.
cases.
Um,
So prostaglandin is in the line of medical therapy. Prostaglandin drugs
is
are,
con
yeah, so they are in what line?
Ma'am, these are prostaglandin analogs are
They are the second line drug, they are the third line drug.
then this is the first line drug.
Very good.
Yeah.
So then why we are not giving the first line drug for the patient?
Because they lead to macular edema in this case.
Why in this case particularly? If it has to lead to macular edema, it will lead to in every case.
Yeah. Okay, no, ma'am, I am not aware of that. Yeah.
Okay, Dr. Shumaila.
Yeah.
Thank you.
Thank you, ma'am.
Sachin sir, your questions, please.
No, I think it's pretty well covered. I think it was more like a discussion than a case presentation because already all the work was done of the research and the references. So the only thing is that these words, when you speak in the exam, have to be very specific. Like specular reflection is an examination, specular microscopy is an
Yes, sir.
investigation.
Yes, sir.
You have to
Yes,
be
sir.
very careful.
Yeah,
And
I'll be careful. Yeah. Yeah.
retroillumination is not the first. Although you can see endothelial details on retroillumination, but you won't see the characteristics which you see on specular reflection. So whenever you mention that, first is specular reflection, and then retroillumination is a what you call what I would say is corroborative. But specular reflection is the one that is expected. Secondly,
Yeah.
as Dr. Devang has already pointed out to you, you have to know the most salient features. And as she rightly pointed, it's a middle-aged female with monocular presentation and chorectopia is very, very classical. Because
Yes,
all the others, which other syndrome looks exactly similar to this with chorectopia?
sir. Correct. Yeah. Sir, in progressive iris atrophy, we have polychoria more than correctopia, whereas in Cogan-Rees, we can have some amount of correctopia.
No. Which is the other differential which has a similar picture, which is early onset and bilateral.
Sir, Axenfeld-Rieger syndrome.
Yes. So Axenfeld triggers has a similar picture, but always bilateral, always in the young.
Yes, sir.
And yeah, so this is something that you need, and the other systemic associations are there.
Yes, sir. Yes, sir.
So if you see only per se the iris and anterior segment picture, it looks like that. So,
Yeah.
but this is clinching what she has said. These three features, and whenever you are asked about the investigations per se, the diagnosis at how will you diagnose? You cannot mention investigations. Investigations come after your clinical examination. So
Okay.
don't
Right.
confuse that when you have a provisional and your final diagnosis, you cannot jump to investigations before that. Just always remember this when you're presenting.
Yeah. Yes, sir.
Yeah. And if you don't know something, like for example, you just avoid that question, you say you don't know, that's fine. Rather than answering something and then you will be taken off track completely. So avoid that kind of those kind of answers. Okay. Otherwise, well presented.
Thank you. Thank you, sir.
Yeah. So can we move to the next case?
Yes, ma'am.
Dr. Sachin sir and Dr. Devang ma'am, can we move to the next case?
Yes, yes, please. Go ahead.
Sure.
Thank you, Shumaila. And Rekha ma'am, if you are in a hurry, you can give your comments or give your feedback. Anushri, please stop sharing.
Thanks, MOS, for giving the opportunity for this is a wonderful way to ask residents to present and then questions can be asked. So thank you so much, Sachin and Devang, both.
Thank you, ma'am.
Thank you, ma'am.
And
Yeah,
thank you for
thank you. And she's done very good homework under your guidance. So that's
Yeah,
nice.
Thank you.
Mhm. So with that, we'll move on to next case, and the next case will be presented by Dr. Anushri Kadam. And she's mentored by Dr. Sumita Karandikar ma'am, and she's a junior resident at D.Y. Patil Medical College, Mumbai. So Anushri, over to you.
Thank you, ma'am. Good evening. I'm Dr. Anushri Kadam, and I'll be presenting a case of primary angle closure glaucoma. I'm mentored by Dr. Sumita Karandikar ma'am, the HOD at D.Y. Patil School of Medicine, Navi Mumbai. Okay. Surekha Mahajan, a 45-year-old female from Domivali, who is a homemaker, presented with the chief complaint of gradual progressive diminution of vision in last 6 months. She also complained of itching and burning sensation in both eyes for 1 month. On elaborating the origin, duration, and progress of illness of the patient was relatively all right 6 months ago, where she started developing a diminution of vision, which was gradual and progressive. Left eye was more affected than the right eye for both distant and near vision. It was not associated with colored halos, redness of the eyes, headache, or any other ocular pain. Itching and watering of both the eyes were also her complaints for 1 month with burning sensation. She complained that the sticky discharge was present, which was more in the morning. She did not have any complaint of redness or purulent discharge or any severe pain. She had a history of spectacle use since 4 to 5 years, but she stopped using the spectacles because she was not comfortable. Patient was diagnosed as a case of glaucoma recently at another eye clinic. She was started on an eye drop latanoprost once in the evening and eye drop Hyla PF, which is sodium hyaluronate 0.1%, 4 times a day. There was no similar complaint in the past. The patient is nil systemic and she had no history of head or ocular trauma or ocular surgery. Personal history was not significant, and she had her father had a history of glaucoma, but the further documents were not available. On general examination, she was well built, well nourished, conscious, cooperative, and well oriented to time, place, and person. Systemic examination was also within normal limits. On ophthalmological examination, she had normal head posture, symmetrical face. The extraocular muscle movements of both right and left eye were full, free, and painless. Hirschberg and cover test showed orthotropia. The visual acuity in the right eye was 6.9, improving to 6.6 parts, and the left eye was 6.9 parts, improving to 6.9. The near vision unaided also was N6 in both the eyes, and color vision was 16/16. On slit lamp examination, the lids and adnexia in both the eyes were normal, conjunctiva, cornea were clear. The anterior chamber was quiet, but on Van Herrick grading, it showed grade 2, which is shallow. The color pattern of the iris was normal. Pupils were circular, constricting, and reactive to light, and lens of both the eyes was immature, senile, showing immature senile cataract. Intraocular pressure taken at 10:20 a.m. undilated for the right eye was 20 and the left eye was 22. On pachymetry, the corrected IOP was 22 in the right eye and left eye was 24. On gonioscopy, we found that 3 angles of the right eye and 3 angles of the left eye were occludable, with pars present in one quadrant, which is peripheral anterior synechia. And in the left eye, they were present in two quadrants. According to Schaeffer's classification, we could tell that they were occludable angles. An undilated fundus examination was carried out, according to which the right eye had 0.5 cup disc. Rest everything seemed normal or within normal limits. Left eye had a 0.8 cup disc with which the disc was circular. Inferior temporal and superior rim thinning was observed. The blood vessels were tortuous and macula within normal limit with foveal reflex present. Perimetry for both the eyes was carried out, and the left eye showed a constricting sort of field defect. The provisional diagnosis, according to the ISGEO classification, was probably the left eye is primary angle closure glaucoma, the right eye is primary angle closure. Based on the clinical classification, we can say it could have been a subacute or intermittent PACG case. My differentials were plateau iris syndrome, mixed glaucoma, inflammatory cause of the angle closure. This is the classification according to which we gave a provisional diagnosis for the patient. Now, the patient was planned for peripheral iridotomy for both the eyes, and this is the picture. Patient was taken off of the eye drop latanoprost and started on eye drop timolol twice per day, eye drop brinzolamide 1% with a combination of brimonidine 0.2% twice per day. Eye drop sodium hyaluronate 0.1% 4 times per day was continued. On following visits, we monitored her IOP, and there was a significant decline in the IOP by week 5, and the pressures were 16 in both the eyes. The patient has been following up regularly, and we have stopped the eye drop timolol for the right eye and continued the 3 molecules for the left eye. Thank you.
Thank you, Dr. Anushri, for that wonderful guest presentation. And as Dr. Devang has to leave early, I'll request her to start asking her questions, and then I'll request Dr. Sachin sir to ask her the questions. So, Devang ma'am.
Yes.
Anushri, I would like to ask you that how did you come to this diagnosis?
Ma'am, the intraocular pressure was higher, but it was not as high to cause any alarms about acute angle closure. But at the same time, the angles out of 3 of the angles seemed occluded. I mean, at least they were possibly going to get occluded. Impending occlusion could be seen. So that's why we were leaning more towards angle closure glaucoma. But on gonioscopy, after that, after the perimetry was done, we decided that the visual field defect is also being seen along with the fundus examination showing a cupping in the left eye. So that's why we diagnosed the
How much
patient.
was the fundus? What was the on fundus? What did you see? Fundus evaluation?
In the left eye, which was more having more diminution of vision, we saw 0.8 cup disc with a rim thinning of superior, temporal, and inferior rim thinning we saw.
And what about the right eye?
The right eye's cup disc was 0.4, and it did not show any glaucomatous changes at that time.
So then you have made a diagnosis of what?
For the left eye, we have made the diagnosis of primary angle closure glaucoma. But the right eye, we have diagnosed it as primary angle closure according to ISGEO classification.
So what is PAC?
PAC has an iridotrabecular contact more than 180 degree. It may or may not have elevated IOP, or may not have peripheral anterior synechia, but it does not have any glaucomatous optic neuropathy.
So in your case, what was there on gonioscopy?
On gonioscopy, we had iridotrabecular contact for more than 180 degree. PAS was present, but the PAS was not very significant, like 1 or 2 few PAS we could see, but they were definitely present in one quadrant at least. But after doing fundoscopy, we realized that only one eye had a glaucomatous optic disc.
No,
So
see, Anushri, you have to understand what the examiner's question is. Dr.
Okay.
Devang is asking you
Okay.
the findings of gonioscopy. So limit yourself to gonioscopy findings.
Oh, okay.
Why
Okay,
she's asking you justification why you called it PAC.
okay.
Yeah, so limit yourself to that.
Okay, sir.
Okay, so and gonioscopy of the left eye.
Gonioscopy of the left eye showed again Schwalbe's line was seen in 3 quadrants with PAS present in 1 quadrant with trabecular meshwork.
So in
So
this, one thing you have to remember is, unfortunately for you, your examiner is Devang, one of your examiners. And the best classification of angle closure or on gonios or angle on gonioscopy is the RP center classification. Do you know it? Because if she is the examiner and you don't say RP center classification, Dr. Devang, what we should do?
You should know
So,
basic.
so
There is
that is the easiest and the most universal classification of angle. Angles on gonioscopy. So first thing, do you know the RP center classification, Anushri?
no, sir, I don't.
Yeah. So Schaefer's classification, nobody of us uses, at least not in the GSI, not anywhere, because it's very, very simple to do the RP center classification.
Okay.
Because now we are getting so much confused in talking about the angle, it will never happen if you do the RP center classification.
Okay.
In gonioscopy, again, you said 3 angles are open, which is a misnomer. It is 3 quadrants are open or 3 quadrants are shut.
Okay.
So whenever you are writing down, you be careful about what words you are using. It's very, very important.
Okay.
And that you have to practice. Otherwise, this nomenclature will not come wrong if you practice well. You will never say 3 angles are open.
Okay.
Do you realize that mistake of yours?
Yes, I just
3 angles are open, not 3 quadrants.
got it, sir.
That is very important. And RP center classification is the one which you should refer to henceforth in all your presentations.
Okay, sir.
Yeah, Dr. Devang, anything you want to add about gonioscopy
also,
further?
Dr. Anushri, you had mentioned that Schwalbe's line was visible. It is not Schwalbe's line. It is the posterior trabecular meshwork that we are looking at. If that is not visible, then you say that the angle is occludable or it is closed.
Okay.
Right?
Yes, ma'am.
As Dr. Sachin pointed out, your nomenclature or the words that you use, they are so important that if you use some other words, you will lose your marks.
Okay.
So you have to use very specific terms instead of using very, gross terms.
Okay.
So
Got it.
it's like you speak for 2 minutes and you speak just one word. You will get 100% if you speak the correct word. Vis-a-vis, if you speak for 2 minutes and don't speak that word, you might not get your points.
Correct.
Okay.
Right.
Thank you.
Yeah, so can you just roll back your slides, please, once from the beginning? And limit your history only to positive findings most of the time, because all the other things will not be, you know.
Okay.
Yeah, and here, yeah, okay. So, for example, here itching, burning, and all those things are not going to matter much.
Okay.
Go to the next this thing. So, don't waste too much time. It's not saying don't mention, but don't waste too much time in describing those symptoms. Spectacle use since 4 to 5 years, you said.
Yes,
You
sir.
said not comfortable at present. Did you try to find out what kind of spectacle errors she had?
Sir, she was a hypometropic patient.
So she told you she's a hypermetro?
No, sir. We on doing her the lensometry. We on lensometer we checked for her glass number. So it was plus 1.5.
Okay, why is it important?
So hypometropic patients are generally more predisposed to having angle closure because they have smaller eyes and smaller dimensions of the eyes.
Okay, so these myopes are not predisposed or for angle closure?
The probability is little more for hypometropic patients.
Okay, fine. We'll go to the next slide. Okay, Latinoprost, similar complaints in the past. Diabetes, hypertension. Okay. She was diagnosed at some other clinic and started on this. Okay, next slide, please. Next slide, please. Next slide, please. Okay. So this Van Erichs is okay, fine, but there is another way of grading the chamber by corneal thickness also. Okay, so that is one thing that you should know. That's what we use normally as glaucoma specialists now. Van Erich is something which we do not use as glaucoma specialists. So So you know that it is fine. Otherwise, still this is acceptable as far as the exams are concerned. The intraocular pressure is 20 and 22. Go next page, please. Okay, so here is your mistake. 3 angles occludable which you have written. Okay, so this is called as a goniogram, and goniogram is very important, and you have to mention what structure you see, and whenever you written trabecular meshwork there, you have to write what kind of pigmentation is there in trabecular meshwork. You can't just write TM.
Okay.
Okay, and pass, you have to specify pass also. Solitary pass, 2 pass, 3 pass, generalized pass, whatever. So all those things are to be defined. Gonioscopy has to be basically a pictorial a written representation of a picture. So a person should be able to visualize the angle by reading your gonioscopy findings. It should be that descriptive.
Okay.
Okay. Okay, next slide, please. Now, is this your patient's image or is representative image?
No. Patient was like,
Representative image. Yeah,
yes.
because this is a Caucasian eye. Okay, next. Ocular.
This is also a representative image. We do not
But
have.
why didn't you document those images for case presentation? I mean, you should ideally do it because
Yes,
then
sir.
otherwise you cannot confirm your findings. No?
Yes, sir.
And also, Anushri, if you don't have disk, access, you can also draw it.
Yeah, draw it. Yes,
A piece of paper
drawing the disc is
and
very important.
yeah. So that is
Okay.
very important. That is not an excuse that you didn't have this. You could have easily done that. Okay.
Okay.
Drawing disc diagrams are very, very important, and they are non-negotiable. As she said, you cannot go without a disc diagram and go without a goniogram for a glaucoma case.
Okay.
Temporal tortuous macular, inferior temporal, superior thinning. So here, what you have described in your fundus findings, you think you should add something more? You just mentioned the shape of the disc, and you just mentioned rim. You not mentioned the color of the disc. You not mentioned the peripapillary area. Not mentioned if any nerve fiber layer defects are visible, which I think should be visible with a disc this bad. Not always, but most of the time.
Okay.
So all those telltale signs of glaucoma you should be knowing.
Okay, sir. Yes, sir.
Okay. Go to the next slide. Okay, so this is the perimetry of the patient, or
Yes, sir. This is the real perimetry of the patient.
okay. And go to the next slide. So you said the right eye, both eyes were occludable,
Yes, sir.
and you said one eye had a solitary pass, and the other eye, gonioscopy findings. Can you go back again? Yeah. So here you had open till Schwalbe's line and trabecular meshwork in the right eye, and Schwalbe's line again trabecular meshwork in left eye with pass more in the left than the right. Okay, fine. No problem. So you already had a pass in the right eye with a
Yes, sir.
normal eye pressure. So that's why you classified it as a
PAC.
what are the various these things types the stages in the classification in the ECGO?
It is PACS, which is primary angle closure suspect,
Yeah.
primary angle closure, and primary angle closure glaucoma.
Okay. So this you feel is a PAC because there is a presence of synechia.
Yes, sir.
Okay. And what
But there is no glaucomatous optic disc. That's
correct.
the
Correct. In the other eye, but then if you go to your next slide, go to the slide of perimetry. If you are saying that the patient's disc is normal, why the field is like this in the right eye?
uh,
What is this visual field defect which you see in the right eye? Is it a normal field or abnormal field?
it's abnormal, but it's not. Sorry, sir, I don't know.
Yeah. So you have to understand that there is a learning curve in visual field. So if the field test is done for the first time, there might be defects which can be attributed to the learning curve. But the point is, these defects are in the accurate area. These defects are looking slightly glaucomatous. So you have to be sure that your disc examination has been okay.
Okay.
And you have to have, did you do imaging for this patient?
We could not, sir.
Yeah, because if the even if the cup disc ratio is normal or supposedly around 0.5, it may not be necessarily a normal disc. And that can still give you a field which is like this.
Okay.
And that is something that you should remember. That's why in investigations, you should have an imaging, especially in early to moderate glaucomas, or because these things will be picked up there. Okay, next slide. Next slide. Okay, so this is the classification that you put up. Okay, next slide. Okay, so peripheral iridotomy was planned because you thought it was an angle closure.
Yes, sir.
And patient was taken off eye drop and started for both eyes on timolol. And you also started the patient on brinzolamide and brimonidine.
Yes, sir.
Why so?
Sir, we wanted to give a 3-molecule.
Why 3 molecules? What was the starting pressure of the patient?
The starting pressure was 20 in the right eye. The corrected pressure was 22 in the right eye and 24 in the left eye.
No, but that is treatment naive pressure, or patient was already on medications and the pressure was that much?
This patient was already on medication.
That was on Latopros RT, right? What you
Latopros,
said.
yes.
So on a single drug, he had 22 and 24.
Yes, sir.
So why do you need 3 drugs for the pressure lowering in a case, especially when the right eye is a PAC and left eye is a PACG? PACG I can understand. What about PAC? Why
Sir,
you want 3 drugs?
So we wanted to start a faster effect with timolol and
No. What is target pressure?
21.
No, what is target intraocular pressure? Define.
I don't know, sir.
So this is, if you have, whenever you are presenting a glaucoma case, this is very fundamental for your starting treatment, that you should know what is target intraocular pressure. If you don't know definition of target IOP, how do you start medical treatment? You are not justified in starting medical treatment if you don't know definition of target IOP.
Okay, sir.
So for this is very fundamental. So this is not very hi-fi question. This is the kind of pressure that you need to prevent progression in glaucoma. Okay, so your aim of treatment is to prevent progression if it is a glaucoma, or prevent conversion if it is not a glaucoma, if it is ocular hypertension. So that level of pressure will be different for these 2 eyes, because one is having a advanced glaucoma as far as the perimetry is showing, and the right eye, I don't know. I mean, we'll have to cross verify either the field test is a learning curve or whether it's a early glaucoma. But definitely medications will not be same in both eyes, because target IOP will be vastly different. So this is fundamentally not a very accurate representation what you have given. You will have to revisit the findings, whether you have written wrongly from the notes. Maybe actually it is that it's more drugs in the one eye as compared to the other. Okay, next, go to the next page. So you said on following a decline in state consistently maintained and followed up regularly and monitored for changes, timolol was withdrawn for right eye. So why did you withdraw timolol, and why did you start the patient on brinzolamide brimonidine? Why do you want to, when a patient doesn't have glaucoma, why you want to put the patient on a fixed drug combination?
So the IOP was higher than what?
No, it was 20 and 22, no?
22 and 24.
22 and 24, fine. But even if the IOP is 22 and 24, you did not put. And what is the problem with what are the most common adverse effects with brimonidine? Do you know?
Yes, sir.
So brimonidine produces a lot of redness and itching. So it's not a friendly drop to have.
Yes.
So you will never, if it is not medically contraindicated, you will never prefer a brimonidine brinzolamide over a timolol, unless timolol is contraindicated in some circumstances. And why was a prostaglandin stopped in this case?
So we wanted to do peripheral iridotomy and
Okay, but after you did a peripheral iridotomy on follow-up, why did you restart the prostaglandin?
after this step, we were going to restart. We are planning to restart the latanoprost.
Okay, and eye drop timolol combination of this was continued in the left eye. Fine. Go to the next slide. I think this is the last slide. Okay.
Yes, sir.
So here there are two fundamental things you should understand. Was there a gonioscopy done after the laser?
Yes, sir. It was done.
So what did it show?
It showed at least till trabecular meshwork we could see in all the angles. There was significant difference.
No. Whether the angle was still occludable or not occludable. Very
So
simple.
no, it was not
Angle was
occluded.
not occludable after peripheral iridotomy.
No, sir.
Okay. So all the more reason you should have gone back to a prostaglandin, which is because it's the first line treatment. No?
Yes, sir.
And if after iridotomy the angle was still occludable, what do you call it?
Um,
Or what would you suspect in that case?
if it is still occludable, then plateau iris
Yes. So
syndrome.
whenever it is occludable, even post PI, plateau iris is one of the definite considerations. And what are the drug of choice for plateau iris?
Prostaglandin.
Would I ask you if that was the answer? Yeah. No. So it is pilocarpine because you have
Okay.
to remove the occludability. So one of the indications of pilocarpine in modern day glaucoma practice is plateau iris. So remember this, it's a very important drug, and pilocarpine is the drug which is important in angle closure in certain cases. Not all cases, but in this case, definitely if your angle is not occludable post iridotomy, and here it is very important you mention that you have done a gonioscopy post iridotomy, which you have not mentioned here. So whenever you're talking in the exams, you say that I would like to do a gonioscopy after my iridotomy to check the effects and confirm my diagnosis, because diagnosis may change. If the angle still does not open, it's slightly occludable, you know it can be a anteriorly placed ciliary body, something like a plateau iris, where the treatment is vastly different from what would happen if the angle is not occludable after a PI.
Okay.
So in this case, the treatment of choice, if the ocular hypertension in your right eye still persists, would be a prostaglandin as a first line, because you have to go for minimum frequency of instillation and maximum impact. You would definitely not put in a brimonidine brinzolamide. Whereas even for the left eye, that would come as the third and fourth line. So in the left eye, your timolol, unless contraindicated, timolol and prostaglandin would be the first two drugs to be used, even after a PI. So that is something that you should know.
Okay.
Okay. Dr. Devang, are you here?
I think she has left because she had some meeting.
Okay, not a problem.
Yeah.
If you want to add anything, you can add, madam.
Yeah. Can you stop sharing the screen?
Yes, ma'am.
So can you ask her about the optic disc changes in glaucoma, because these are like more frequently asked questions in MS exam. Like
No,
the...
madam, you also can ask, no problem. You can go ahead.
No. Since you
Because
are
I am
yeah.
more detached from the exams nowadays. So yeah, so you can describe whatever. The optic nerve head changes in glaucoma. You can describe what all do you see in the optic nerve head.
There's a large cup disc ratio. The optic nerve will have the neuroretinal rim thinning will be seen. There could be notching of the optic disc.
Notching of the disc.
Rim.
Again, I am saying.
Rim. There is lamellar dot sign, but lamellar dot sign is a non-specific sign, but generally it is seen. There is I'm sorry, I'm not able to remember.
Don't take pressure. This is not an exam. Relax and answer, no problem.
There are blood vessel changes like bayoneting sign can be seen. The cup is also deeper.
Okay.
Bayoneting of blood vessels. The cup is deeper.
There is a systematic way of how you proceed. Then it will not be so haphazard in your mind. follow a sequence. No? Go from the disc, size, shape, color, margins, neuroretinal rim. Then you go to the peripapillary atrophy, disc hemorrhages, RNFL defects, or wedge-shaped or slit-like RNFL defects. So go in a systematic sequence. Just imagine actually you're looking at the disc and go from one structure to the other. Then some things are there like bearing of circumlinear vessels, nasalization of vessels, all those things are there, which are relatively less important now, but they are the signs of glaucomatous disc. The most important is to see the inter-eye asymmetry, which you should never forget.
What is
Because
normal?
otherwise, a cup disc ratio of 0.5 can also be glaucoma, 0.4 also can be glaucoma if the other is 0.1. So this is very important for you to understand. Yeah, yeah, madam.
What is normal cup disc ratio? And in which direction you said there is enlargement of the cup.
Yes, ma'am.
So, yeah,
0.3 to 0.5 cup disc.
okay. And vertical elongation is more important or horizontal widening of the cup is more important?
Vertical.
What is the normal size of the optic disc and what is the normal size of the optic cup? Normal size of the optic disc. We say 1 disc diameter.
Yeah, and 1500 micrometers.
Okay. And what happens in glaucoma?
There is atrophy of the retinal nerve fibers.
So how do you, when you assess clinically, how do you assess the disc size on biomicroscopy?
Which is the best method to examine the disc? Is it direct ophthalmoscopy or indirect ophthalmoscopy or slit lamp biomicroscopy?
Slit lamp biomicroscopy.
Okay, so how do you determine the size of the disc and the cup?
Do you do it normally or you don't do it? Because then you'll not be able to answer. When
We
you
do it.
examine a patient for glaucoma or whatever, do you do a 90D or a 78D examination? Do you do or
Yes.
not do?
Yes, sir.
Okay. So there you do not measure the disc size as a practice.
We do.
So how do you measure? That's a simple question.
You have to measure the vertical disc. Okay, you can read about it. You can. What are trans hemorrhages?
Um,
What is bayoneting? You mentioned there's some bayoneting sign.
yes, ma'am. It is the angulation of the blood vessels which are coming out from the optic disc. So generally they are not as angulated, but in case of glaucomatous disc, because the disc is deeper and thinner, so they have two angulations when they come out of the optic disc.
Okay, you can read about it more. And trans hemorrhages are the hemorrhages which are seen either at the disc margin or they can also be seen on the surface of the disc. Are they reversible or they are not reversible? And what do they suggest? Suppose today you have seen a patient and patient does not have a hemorrhage today, but after 3 months you see that patient again and you see a superficial hemorrhage at the optic disc margin. What does this indicate?
Further ischemia is happening. So like
It means the glaucoma is not under control. And again, if you control, then what will happen to the hemorrhage? Will it disappear or it will remain there? Read about it, okay?
yes, ma'am. Yes.
And sir mentioned something about peripapillary atrophy. Do you have any idea?
No, other than the fact that it's all the sign of
The beta zone, with an alpha zone, which zone is
yes.
important? What is haloglaucomatosis? Do you have any idea? Okay. But then you must read because these are all for MS examination, these are very, very basic questions. I mean, I have not asked you anything which is beyond basic. So you must know all these questions. So I'll move to Sachin sir again, and because since he's the examiner, I mean, you can.
Yeah, I think pretty much tasks are everything, and I think the points that need to be covered for all other students also we mentioned, like the classifications, the classification of chamber depth, the classification of gonioscopy. So all these are standard. You cannot these are, and you should not be wasting time in inaccurate descriptions at this level, because then the discussion will not go into the management of the case. So that is something that you should learn and practice, because this will come only with practice. So making mistakes during practice is fine, but then in the exams, if you spend time here, then the chances of you reaching scoring levels becomes very less.
Yeah, so with Sachin sir's permission, now we are towards the end of this webinar. So I'll ask Deepa ma'am for her feedback, and then Sumita Karandikar ma'am for her feedback.
Hello.
Yeah, yes, ma'am, you're audible.
Yeah, both of them presented well.
Yeah.
Shumaila, again, I have we are like, you make some, whenever you present a case in glaucoma, you have to make optic disc diagrams. Though we have imaging also, but still, for both the students, optic disc diagram is important. And and you cannot show these pictures during exam. So try to write down your goniogram and as well as optic disc diagram. That is necessary for PG exams. Rest clinical features can be better described for both the students. And gonioscopy, the two points which we stress upon is gonioscopy and optic disc. So go through all the changes that you see in different cases of glaucoma in gonioscopy, and optic disc changes. It should be on your tips. There is no excuse for that.
Correct.
When you are presenting a case of glaucoma, whether it is present in your case or not, if it is not present in your case, then say that I have seen that and it's not present, right? You have to give negative also. Okay? It was not seen in your case, right? So that's important. Rest is okay.
Thank
No,
you.
I think what she's pointed out, Dr. Deepa, is very important, that whenever you have these PG related case presentations, I don't think we should be allowing them photographs and this.
Nothing is
The
allowed.
simple reason is, I'll tell you why. Because we are actually training them for the exam. Then let it be like the exam where, they have to draw the fundus diagrams and no, and maybe we can add the investigations later for a discussion scenario. But from the till the diagnosis point of view, I think when they're presenting, they should definitely present these diagrams. They should present gonioscopy findings not on animations but actually handwritten. I think that will make them more ready for the exams.
Yes, right.
That's a very valid point, Dr. Deepa, I think.
Yeah. Thank you, ma'am, for that piece of advice, take home message. And Dr. Sumita ma'am, are you there? Karandikar ma'am?
Yeah, I am there.
Yes,
Can you
ma'am.
hear me? Yeah.
Yeah, loud and clear.
Yeah. Thanks to MOS for giving us this opportunity. And I think it's very nicely summed by all of you. What are the important points? So I think this MOS gives a good opportunity for PGs to come at this platform, and the outside examiners can examine them. And I think all the things which are required, it's nicely summed up by all of you. So.
Okay. So thank you, ma'am. Thank you for your feedback. And I would like to thank Sachin sir and Devang ma'am for accepting our invitation. And they did a wonderful job. And it was like more of teaching than asking questions. So I also learned a lot from both of them. So thank you, sir. And good job, Anushri and Shumaila. And I hope you have like a lot of take-home messages from all the examiners, and now you know how to prepare a case of glaucoma. And this webinar will definitely help all the students who are watching it or who will watch it later. So on behalf of Maharashtra Ophthalmic Society, I thank everybody, and thank you Deepa ma'am, and thank you Sumita ma'am for mentoring your students. So
I think, yeah, MOS, I just interject here. MOS is doing a wonderful job. Dr. Archana also very nice, and I think gives a good platform and gives good confidence for the students also. So I think it should encourage more and more students. And secondly, this is an archive, so everybody can go back and see their own mistakes and learn from the friends' mistakes. It's not about and this doing it on a public forum gives confidence to present in the exams. So exams becomes just another day in office. That is very important. But having said that, they have to practice a lot
yeah,
because the standard performers you cannot go wrong.
yeah,
As
and
I said,
we
you
get
have
a
to reach
very
the
good
discussion stage as soon as possible. That should be your skill.
Yeah, we get a very good feedback from all over Maharashtra because these webinars are available on YouTube. Students, though not today, they can watch them later. So we are trying our best. Yeah.
Yes,
And
wonderful.
thank you, Sunilji, and thank you, Entod, for all the technical support. So with that, thank you, everybody, and we'll end this webinar. Thank you.
Thank you for the opportunity.